Hello, everybody. Thank you all so much for joining us today. I'm Michael Weinberg, the Executive Director of the Engelberg Center on Innovation Law and Policy here at NYU Law. We are really excited to co-host today's event with the Journal on Intellectual Property and Entertainment Law. The event focuses on the role and impact of US innovation policy on access to medicines. The Engelberg Center focuses on a wide range of work related to innovation, from open access to algorithmic discrimination to, of course, access to medicines. While the Engelberg Center has a rich history of exploring issues related to the relationship between innovation policy and medicines, the past year has introduced this idea and this important issue to a much wider audience. We hope that this event is a welcome introduction to those of you who are new to the area, as well as a rich discussion for those of you who have been working on it for years. First, I want to thank the staff of the Journal of Intellectual Property and Entertainment Law, Engelberg Center Fellow and NYU Tech Law and Policy Clinic Deputy Director Chris Morton, and of course, all of our moderators and panelist participants for making this happen. If you enjoy this event, I hope you will join us for other Engelberg Center events in the future, both online and soon enough, hopefully, in person. The best way to find out about these events is to join our email list from our homepage or to follow us on Twitter. With that, I want to thank everyone again for joining us today and hand things over to my co-host, Zach Bass, who is much better dressed than I am, the editor-in-chief of NYU's Journal on Intellectual Property and Entertainment Law. Zach?
I'm wearing my power tie, so that's why. Thank you, Michael. Thank you very much. Good afternoon, everyone. My name is Zach Bass, and I'm the editor-in-chief of the NYU Journal of Intellectual Property and Entertainment Law. On behalf of our team, we welcome you to our 2021 Symposium, Access to Medicine, the Role and Impact of U.S. Innovation Policy. Now, I'm not kidding myself. Those of you in attendance are not here to listen to me, so I will try to be brief in my opening remarks. First, I would like to thank those most responsible for this event: Michael Weinberg, Chris Morton, Kevin Chow, Rachel Gallagher, the Engelberg Center on Innovation Law and Policy for their guidance and resourcefulness, NYU Law for serving as an excellent host for intellectual conversations such as these, and finally, our moderators and panelists who are truly the reason why this is a special event. Second, I would like to briefly go over logistics regarding CLE credits, which I know is important for many of you. This event has been approved for a total of 4.5 hours of New York State CLE credits in areas of professional practice and is appropriate for both newly admitted and experienced attorneys. Each panel will have its own unique code that will be announced at some point during the panels themselves. If you are interested in obtaining CLEs for this event, please make sure you have downloaded the attestation form and record the codes accordingly. You should have received an email from us with the form. If you can't find the form, you can also download it from the Symposium Eventbrite page through the download link in the CLE section. Importantly, please ensure that your Zoom display name matches the name that appears on the form. The event format is a web conference, and the CLE provider is the NYU Journal of Intellectual Property and Entertainment Law. Shortly after the close of the symposium, you should receive via email a Google link to upload your form. And for any questions related to CLEs for this event, please contact Kevin Chow at kq364@nyu.edu. Thirdly, I would be remiss if I neglected to mention the work of our journal. The NYU Journal of Intellectual Property and Entertainment Law celebrates a decade of publication this year. And in that decade, we have grown from a small blog to a staff of 60 editors, publishing articles discussed in Billboard magazine, to The View, to Live with Kelly and Ryan. For those authors in attendance, we would love to work with you. Finally, a word on this symposium. This is certainly not the first event dedicated to medicinal access, and I doubt it will be the last. Nonetheless, there's never been a time where discussions regarding American innovation policy have been more important. The Trump administration's Operation Warp Speed was unprecedented. Billions of government dollars have been spent expediting the development of COVID-19 vaccines. For the most part, it seems to have been successful. Multiple vaccines have withstood the FDA process, and the Biden administration anticipates that national access might be attainable by this summer. In all likelihood, many in the audience have already received a vaccine. However, we must ask, is this the new norm? Is the federal government going to continue to play a more active role in bringing about medicinal access going forward? This event addresses these questions through 4 separate panels, each dedicated to a different facet of the issue, varying from insurance subsidies to the Bayh-Dole Act to the prosecutorial enforcement of antitrust law in the pharmaceutical sphere. Most importantly, our team sought to craft diverse panels, divided panels, panels consisting of big pharma representatives, founders of activist groups, leading academics, top attorneys, and of course, Judge Young of the District of Massachusetts. As a result, I doubt you will see a consensus on any of the 4 issues presented today. And these issues strike at the heart of what obligations must government fulfill. Despite this, I believe that all of us, including you, believe that access to medicine must be a national priority. How best to achieve that goal will be the focus of today. With that said, I hope you enjoy this event. For those interested in asking questions for our panelists, I cannot guarantee that they will accept them. However, some panels have dedicated 10 minutes or so to questions, others have not. Regardless, please use the Q&A feature of Zoom, which should be located down below, to ask, not the chat. With that said, it is currently 12:23. Our first panel will start at 12:30, and I will give an introduction for the moderator of that panel when it comes time. Thank you. Hello again, everybody. During our brief little intermission, someone was asking whether we have a hashtag. This goes to show why I should have a Twitter. Our hashtag is going to be hashtag NYUA2M. That is NYUA2M. Let's make this viral. With that being said, our first panel will be focused on the following. How should governments use insurance subsidies in purchasing to set rewards for medical innovation? And it will be moderated by Professor Lisa Wallett. Professor Wallett is a professor of law at Stanford University. Her scholarship addresses empirical and theoretical problems in intellectual property and innovation law. Her research explores how scientists use the technical information in patents, how scientific expertise might improve patent examination, the patenting of publicly funded research under the Bayh-Dole Act, and the integration of IP with other levers of innovation policy. She has applied these ideas to biomedical innovation challenges, including the opioid epidemic and the COVID epidemic. And her commentary has appeared in the New York Times, Wall Street Journal, Time Magazine, and Slate. Prior to her appointment at Stanford, Professor Wallett was a postdoctoral fellow at the Information Society Project at Yale Law School. She clerked for Judge Dyke of the U.S. Court of Appeals for the Federal Circuit and Judge Walker Jr. of the U.S. Court of Appeals for the Second Circuit. She holds a JD from Yale Law School and a PhD in physics from Cornell. With that, it is my distinct honor to introduce Professor Lisa Wallett.
Great. Thanks so much, Zach, and to all of the organizers of this amazing symposium. It's very exciting to be kicking this off. And I'm delighted to have an amazing panel to moderate the discussion of. The panelists' full and impressive biographies are available in the program, so I will not go through them in detail. I will just briefly tell you that we have Professor Michael Abramowicz, who's the Oppenheim Professor of Law at GW Law School. Daniel Hemel is a professor of law and the Ronald H. Coase research scholar at the University of Chicago Law School. And Bhaven Sampat is a professor of health policy and management at the Columbia University Mailman School of Public Health. And all three have written extensively on the variety of government policies for rewarding innovation. So I am very excited about this discussion today. And as the first panel of the symposium, I think it is important to reiterate Zach's point that I think everyone participating in this panel and in the symposium more broadly today cares deeply about access to medicines. So even though there will be disagreements throughout about the best policies for achieving these goals, those disagreements come from a place of wanting to save lives and improve health outcomes. So the original framing of this symposium was more focused on the role of government patent rights in increasing access to medicine. And as a preliminary note, I think it's important to recognize the value of pivoting away from government patent rights as the key policy lever here, because the government has direct patent rights over only a very small percentage of drugs, and whether the government has patent rights has little relevance for the system of allocating access to drugs. But the government does have a lot of control in setting both access and rewards without doing anything related to patents through programs like Medicare and Medicaid and the kind of bulk purchasing it's been doing throughout the pandemic and direct government provision. And in designing these institutions, policymakers should recognize that they have independent control over the two elements of innovation policy: how access to those new technologies is allocated in terms of the out-of-pocket costs for patients, and how those technologies are incentivized. So our panel is focused on improving the incentive side of innovation policy while facilitating access. The panels later in the day are focused more directly on access. And I think it's important to remember throughout that in many real healthcare systems, the choice of patents as part of the innovation side of, part of the incentive side of innovation policy doesn't create a trade-off with access. We really can think about these questions separately. So on the incentive side, there are a number of reasons that for medical innovation, market signals are an imperfect signal of social value. And scholars have proposed a number of prize system alternatives. Michael's written a wonderful research handbook chapter on this that I think is in the program materials. Many of the specific prize schemes seem politically unlikely to happen anytime soon. But as scholars such as Rachel Sachs and Ben Rowan have noted, the current US system actually is already somewhat like a prize system and could be even more so. And other countries are even more directly involved in shaping rewards through health technology assessment. So I think the real question facing today's policymakers on the incentive side is how rewards for medical innovation should be set, both how much money should be spent on a given problem, and what institutional mechanisms should be used for distributing those rewards. So the plan for this panel is to focus on those two issues, first focusing on how the size of the reward should be set, and then turning to the institutional structures. And so on this first question of the size for innovation rewards, like whether that money is spent through direct government funding or ex post rewards or something else, like what should be the goal there? I thought I'd start by turning things over to Daniel, who can explain his thinking on these points.
Thanks, Lisa, and thanks to the organizers of the panel. Really happy to be here. I think my number one thought on the size of rewards is that they should be bigger, that we don't spend all that much on pharma. About 12% of total health spending in the United States is on prescription drugs. So prescription drugs are not why healthcare is so expensive in the United States. We devote about 1.6% of GDP to prescription drugs. That seems surprisingly low to me, though it's high by international standards, given that these are the things that in a lot of our cases are going to save our lives. I would like to live in a world in which the top STEM students who want to make a lot of money go to biotech rather than to hedge funds. And I think we can do that, that the trade-off between innovation incentives and access to medicine is a policy choice, i.e. we are choosing to pit those into conflict and we don't need to. A decade ago, that was a major theme of the literature in innovation policy and IP, and it is still to some extent, but I think it's largely a vestige of 1990s austerity politics, that as we are seeing now, the government can spend a lot more money than it does on really important things. And I think saving people's lives is a really important thing. And right now we're seeing big rewards to Pfizer and Moderna and Johnson & Johnson combined with free access to vaccines. So the government could just buy a lot more life-saving drugs and give them out to people for free. And if we look at the values that we use in the innovation context, so the Institute for Clinical and Economic Review uses in its remdesivir evaluation a quality adjusted life year of $50,000. The Department of Transportation, in deciding how much car manufacturers should have to spend to make your roof more crush resistant, or to add a tire pressure monitoring system so that your car doesn't skid out of control, they use a value of a statistical life of $11 million. Right? And those two numbers are only consistent if the average person has 220 more healthy years of life to live. We're using much lower values in the pharma context than we are in other contexts. I think size matters more than exactly how you do it. But ultimately, I think rewards should be based on social value rather than cost. I don't really see an alternative to social value. We want to incentivize researchers to focus on the most promising solutions to the most serious problems. And the way to do that, it seems to me, is to give the largest rewards to the people who come up with the most life-saving solutions and to try to ex ante funnel government investment into the most promising projects.
Great, thanks, Daniel. Michael, I know you've written some about the role that we might play in having the costs that we're spending on R&D playing some role in rewarding innovators. What role do you think that should play compared to thinking about social value?
Yeah, good question. So let me kind of talk about that, and then I'll also talk a little bit about what Daniel talked about in terms of sort of the total amount. So Daniel said, and I agree that, of course, ultimately what we really care about is social value. We want to reward to the extent that we're giving rewards in any form, whether it's patents, whether it's direct government spending, whether it's altering Medicaid or Medicare policy and so forth. We want to give bigger rewards for bigger contributions. I think the trickier question is whether we want to be measuring welfare directly entirely, or whether we want our rewards to be based in part maybe on some kind of direct measure of improvements to welfare, such as measured in QALYs, as he was referring to, or also whether we want to look at inputs like the cost that researchers spend on particular research projects. And I do, there's arguments on both sides. There's a danger to focusing too much on cost, and that might encourage some wasteful spending, right? If we say, well, we'll give you, we'll pay you back twice your costs, then you just spend more, you get more back. So you don't quite want to do that. At the same time, we need to worry a little bit about the need to adjust for risk, right? We can't just say, well, we're going to reimburse your costs if you're successful and not reimburse you if you're not successful. And so I think there's pretty wide agreement in the literature among people with a variety of point of views that to the extent the government is kind of reimbursing costs, we need to take into account risk. The problem is this is not so easy to do. There's a danger of hindsight bias. And I think the more subtle danger, the more subtle difficulty is that a lot of the cost that we want to reimburse is not sort of for the most immediate project that, let's say, a pharmaceutical company undertakes. It's for building the company, building the capacity to undertake that project. And I certainly think we see that with COVID, that, what we're really compensating, Pfizer, Moderna, and so forth for is for building their companies in the first place, bringing people together with expertise who knew how to work together. Not so much the direct outlays on the particular project, that too, of course, but not just that. So those are some dangers of considering cost, but I also think there is a huge benefit in that cost can be a lot easier to measure than social value. And I think that's why we see cost so much in government contracts, why we have cost plus contracts, for example. We just think it tends to be easier to measure cost than social welfare. And so I think in the end, you might want to have some kind of hybrid system, cost less than 100%, so we don't have wasteful spending, as well as some kind of assessment of social welfare. I do want to echo a little bit about what Daniel said about kind of the total amount of spending, but with maybe a different view. My view is we spent way too little in COVID on vaccines, and that we probably could have been a lot further along if we had spent more. If we had built more factories, if the supply chains had gotten going a lot earlier, rather than only, and they got going to some extent a lot earlier, but not as much as they could have until the companies were pretty sure those expenditures were going to be something that they could make money on. And so I worry that if we switch too much to incentivizing pharmaceuticals based on the anticipation that government is going to spend money, or on actual government spending, government's going to spend too little. And I mean, if we only spent whatever it is, however many billions on COVID, but it's billions, but it's not a huge number of billions, then are we really going to trust government to spend enough on other research projects with potential benefits years down the line? And I think overall, yes, we do see the government spend a lot of money on healthcare, on healthcare, but maybe less on research, because the benefits are further down the line. And so I think that's kind of a major problem with our kind of political economy, that we're not quite, we don't have systems that will quite give incentives for political actors to value long-term benefits enough.
Great, thanks. Bhaven, do you want to weigh in here?
Yeah, well, thanks, Lisa, and to the organizers for inviting me to be part of this. To be frank, as I mentioned to Lisa a few months ago, I've thought less about some of these issues, especially the ex post reward issues, than some of my comrades on this panel. So hopefully my reflections here aren't naive. But let me just pick up on a couple of things that that both Michael and Daniel said. My sense, and maybe I'm wrong, is that when we're talking about both R&D costs and also social value, we're talking about two constructs that are notoriously difficult to both operationalize and measure. So on the R&D cost side, from my reading of the accounting literature years ago, there's no great standards on how to think about capitalization, failures, spillovers across projects, and the kinds of infrastructural investments that I think Michael talked about. And then I think social value is even harder. If we took seriously proposals to reward drugs, individual drugs, based on social value, we would have to think through things. And I know a number of people in the audience have started to think through these things, but we would have to think through things like qualities versus dailies, how much a quality is worth, but also like kind of more fundamental issues like discount rates, like how much do we value lives today versus 10 years from now? U.S. versus global disease burden. How much, essentially, what do we weigh each? And I think most importantly, actually measuring the quality gains from a drug. So you run into questions like, what kinds of studies count, what the right comparator is. Do you rely on clinical trial evidence, clinical trials with surrogate endpoints, real world evidence, et cetera, et cetera. And none of this is kind of necessarily insurmountable, but it's hard. I see that Aidan Hollis is here as one of the participants. It's telling to me that one of the serious attempts to do this, the Health Impact Fund, a large share of the projected costs are not for like prize payouts, but rather for like the creating essentially the largest technology assessment enterprise in the world, like 10, 15 times the size of NICE. So I think the general point is, I think the system is broken and I think we should do more and we should spend more, but beyond the kind of theoretical prize discussion or ex post rewards discussion, thinking through the cost of administering whatever system we come through in a principled way, and the kind of political economy of different systems and how they might be subject to or immune from different kinds of disease group politics and whatnot would be useful. My instinct is that from that perspective, R&D cost perspective, reimbursement might actually be easier, but I'm curious as to what others think. And then just like one last thing, I think beyond, I think first the best shouldn't be the enemy of the good here, but I think what we can do more comfortably is ballpark social value for certain things. So, a COVID vaccine, an effective Alzheimer's treatment, things like that, and come up with some lower bounds for social value. And I think it's worth agencies thinking about specific problems in that sort of way. And another useful thing to do might be to create broad proxies for social value. In some sense, we already do. So unmet needs, breakthroughs, treats an important tropical disease or something like that. And then meter our existing policy instruments, everything from FDA exclusivities to patents to maybe even insurance to those in a kind of more blunt sense that moves with our proxies for social value. And I think that's an interesting discussion. But finally, I think a really nice effect of this discussion is just forcing us to step back a little bit and think about the outcomes we want and working backwards from those, rather than the sort of science push or technology push aspect that's characterized a lot of biomedical research policy for the last 75 years or so. So why don't I leave it at that and I look forward to the discussion.
Great, thanks, Bhaven. So we have like 10 minutes or so to continue discussing this, and before turning to this separate question of what institutional mechanism we're using. Daniel, do you want to weigh in on any of the thoughts Michael and Bhaven have shared?
Yeah, I think we probably agree on the panel that if instead of spending 1.6% of GDP on pharma, on prescription drugs, we spent 3.2% of GDP, we would probably have more life-saving treatments. That we do make some of these hard decisions about quality adjusted life years versus disability adjusted life years versus expected value of life years gained in other contexts, in the deciding how clean our air should be or how safe our cars should be. So, and we have that done by the government, and it is politically challenging, but not politically impossible. I think the Institute for Clinical and Economic Review is a good model of how to do this. And we can imagine a world in which Medicare and Medicaid cover a larger portion of the population, and more drug pricing is just set by the government based on a measure of social value that won't be perfect. But I think Bhaven is entirely right that the perfect shouldn't be the enemy of the good. And my one criticism of the way that NHS does it in the UK, or that the Institute for Clinical and Economic Review does it here, is I just think the numbers should be 5x or 10x of where they are now.
I'll jump in if I may. So what I think Daniel may have more confidence in our ability to the political system's ability to kind of measure the qualities and so forth in a reasonable way. And maybe you could create some kind of very independent administrative agency and do it. But I think another thing we've seen in COVID is with the vaccines. Obviously, we have had to ration. I suppose one could debate whether we should ration or have an auction, but we needed some mechanism for allocation, scarce allocation. And I have to say, I don't feel like that any of the state governments have done a particularly commendable job of creating some kind of coherent methodology. Adding up multiple categories. I mean, one like very simple thing that you might think is people would say, well, if you're 64, and you have a serious condition, you should get medicine maybe a little bit before somebody who's 68 and doesn't have a condition. But it's the desire for I don't know if it's a desire for simplicity or maybe more likely a desire to avoid hard value choices has led to a lot of kind of very crude measures. I mean, whether one thinks, however you think the big picture looks in terms of which group should get it first, it's certainly a very crude system that we have. And I'm not convinced that you can kind of eliminate that crudeness, just by, the magic of creating an administrative agency. And by the way, we certainly haven't done that well on equity either in our allocation decisions. There was sort of a debate early in COVID about, well, people recognize that African Americans and Native Americans and so forth had a greater burden from COVID. And so there was a hope that maybe that we could get vaccines to those communities first. And there was a debate, well, should we consider race directly or should we consider zip codes? And of course, the answer is basically we've done more or less done neither. I mean, there's been some attempt to get the vaccine into underprivileged communities. But I think there's a lot of fear of actually creating an allocation system that seems to privilege anyone above anybody else, with the result that any attempts to create more equity are not going to work. And I think the broader problem is, considering lots of variables that might be relevant, doesn't seem to be possible in COVID. And I worry that it won't really be possible to have a serious model-based allocation in anything. And I've been coming around to that view in any event.
I think you're right on the inequities in the allocation that we've seen during COVID. I mean, I think these questions of how we are allocating are, as I said at the beginning, separate from the questions of how we are incentivizing, but that the question of how we are incentivizing raises similar challenges, which I think is part of the point you're making. That, and I think that is part of the reason that the U.S. government has punted largely many of these questions to the private sector, and that enables it politically to avoid making those hard choices of like which disease is more important and which, the kind of explicitly valuing lives in this context. And it's not obvious to me why in other contexts, like Daniel mentioned, and across many other portions of the administrative state, there seems to be more political feasibility in making these kinds of calculations.
I want to pipe in and defend the allocations that are going on right now. I mean, we have basically a healthcare rationing system that popped up all of a sudden, and some of us had some frustrating evenings trying to get vaccine appointments for older relatives. But most of the people I know who are over 65 have had their first shot now. And most of the people who are in their 30s that I know have not had their first shot right now. And that more or less, I'm in a privileged position. Most of the people who I know are top few percenters and predominantly predominantly white. But still, I think if I compare the allocation of vaccines based on risk done by this kind of pop-up federalist disjointed government effort versus allocations that happen just in a market process, and when I'm comparing outcomes over the course of the last few weeks to whether the market really allocates medications to the people who need it the most, I'm more confident in socialized medicine as an access allocation scheme than I would have been before. I think we're doing a better job than just the free market. Michael, those were fighting words.
I want to move to thinking about the kind of institutional mechanisms we should be using, but I want to briefly first, because it's relevant, there's a question from Brooke Baker about the directing funding toward wasteful, inefficient R&D. And I'm curious, so all three of you have said that I think we spend too little on many healthcare innovations, that we would have, if we spent a greater rewards, we would have more life-saving innovations. Do you think there are places where the current system provides too much, such that, so Brooke Baker's question refers to evergreening exclusivities and Me Too drugs, and are there cases where there is wasteful spending in that direction, such that using social value as the lodestar would lower the rewards? Go ahead, Bhaven, you're nodding.
Oh yeah, I mean, I think absolutely, and to pick up on Daniel's points about health technology assessment, yeah, I mean, I think actually a number of the things that I suspect will come up this afternoon, or at least are in the air, like including evergreening and product hopping and all this kind of stuff, that a good technology assessment enterprise could help obviate some of those problems as well. And this is the context in which Daniel brought it up, we could also spend more on more valuable stuff. Now, of course, if the consumer faces that cost, then we run into the Sovaldi problem, where you have a very valuable drug so in some sense you'd want to couple that, and others on this call, I know in this meeting, have thought about this a lot more than I have, but with some sort of insurance coverage to sort of decouple the innovation incentives and the price side of things. But I agree that we could actually, with Brooke's comment, that we could actually reduce expenditures considerably as well through a reasonable HTA apparatus, imperfect as it may be.
And I'll kind of jump in a little bit here. On the evergreening, I mean, I think it's pretty clear that the evergreening probably distorts research in one direction rather than another. I think it's a lot harder to say that the marginal research that's spent on evergreening is actually not cost justified. I mean, I don't know. I think that would be a very hard thing to measure. There's some benefits, from some of the improvements to drugs, and some of that might be cost justified. Back to Daniel said he had some.
But why would it be hard to measure, Michael?
I'm sorry. Why
would it be hard to measure?
Well, I mean, there's a lot of different drugs, a lot of different kinds of innovations, and I think a lot of the concern on evergreening comes from the access side rather than the incentive side. That we're evergreening so that we can keep the prices high. I haven't heard so much, but maybe perhaps you have, in terms of just the idea that the research expenditures on the improvements are themselves not worthwhile. I've certainly heard the argument that those research expenditures on improvements might be better allocated to other kinds of problems if you could kind of magically move those to other kinds of problems. I wanted to very quickly respond to Daniel's fighting words, or I don't know if my words were the fighting words, Daniel, or if yours were. I don't disagree with him altogether, but I think the danger, is that we end up with the worst of both worlds, with both incentives and maybe I'm getting off point here, Lisa, but also, with access. And I think on the free market side, if people really anticipated a free market in which they'd fully be able to exploit their patents, have an auction for the the first however many thousand people who are going to get vaccines, we probably would have gotten it a lot earlier. I think. I think that would have been a plus. I think the downside here is I think there was a sense among pharmaceutical companies that they weren't going to be able to do that. Certainly, if they wanted, emergency use authorizations. And so I think that depressed incentives, to produce quickly. We obviously we still did better than we've done in the past, but this was kind of the worst, public health crisis we had in quite a while. I think we could have done considerably better. And then even after all of that, we didn't do so great in terms of actual allocation, and that makes me worry that our institutions, for not only for allocation, but also for incentives, just aren't very well calibrated. At the least, we need, to have some better institutions if we're going to be relying on government decision making on these issues.
So that's a great chance to pivot to our second dimension of innovation policy here about the institutions, and however much we are spending on innovation problems, there are a lot of different institutional mechanisms that we could use to distribute that funding. So if we decide that more money should be spent on a problem like a vaccine for a disease with pandemic potential, that can be spent through direct ex-ante funding on grants and national labs. It can be spent as ex post rewards through subsidies or purchases. And there are benefits and costs to all of these approaches. So I thought to kick off this discussion, I'd start with Bhaven, who has suggested that the public sector should be more directly involved in late stage pharmaceutical development. So Bhaven, you want to share your thoughts on that? You're muted.
Sorry, I know. Yeah, so basically the idea here, and it connects to some of what will come up, I think, later on this afternoon, is that under the current system, we have a sort of division of labor going back to World War II, where the government focuses on so-called basic research, since there's market failures there, and the private sector, incentivized by patents and high prices, does the applied work, including costly clinical trials. Some exceptions, but at like a 10, 15,000 foot level, looks something like that. And the observation, and it's not unique to me, is that this division of labor is not really God-given. Actually, it's given by Vannevar Bush, who you might be able to see someone sitting behind me on the shelf, who actually, is sort of the architect of post-war innovation policy, and had fairly strong and conservative views about the appropriate roles of government in the economy, including research, and the idea that applied research should be left to industry, and we kind of built an infrastructure around that. But there were critics at the time, including New Dealer Harley Kilgore, who's on the other side of me, even the economist Paul Samuelson, who argued that there's in fact pretty high social returns from government funding of applied research as well. Indeed, World War II, they were writing in the wake of World War II, sort of showed that, and arguably the pandemic does as well. And so Kilgore, it was explicit that government funding should, be aimed at basically fixing market failures on the applied side as well, looking at areas where the market itself doesn't provide the desired outcomes. So where does that work in? How does that work in pharma, and how does that relate? One of the counter arguments to the use of government rights, so march-in rights and whatnot, to promote lower prices and broader access in pharma, is that even where the government owns a key patent, it's still typically the drug industry financing the costly clinical trials and additional development. Again, consistent with this broad division of labor that Bush lays out. But it's not clear that that needs to be the case. So the government could sort of go soup to nuts or end to end, or at least in some cases, and support some of the applied work as well, or contract with industry to do so, and then essentially price at cost or something like that. So the idea is similar to those that Lisa and Dan, and I think Dean Baker, Jerry Reichman, and others have put forth on the idea that maybe the government should be funding trials. But the argument is to start off by doing so in cases where the government already owns a key upstream patent, and sort of fully develop it as a sort of experiment for thinking about how that might work going forward, and give us some data on things like R&D costs and risks and whatnot that would help us with policy design, since right now I think we're sort of flying without a parachute. So that's the general proposal. In terms of institutional mechanisms, I think it's not NIH, but maybe somewhere else at HHS that would administer something like that.
Great, thanks, Bhaven. Michael, do you want to weigh in here? I know you've focused more on ex post rewards and prizes. What do you think of shifting more of the institutional mechanism toward government funding?
Yeah, I mean, I think there's a very strong case for that, and that brings up this question about ex ante versus ex post. And I agree that to the extent that we can have the government fund more clinical trials, for example, that could be very beneficial, not necessarily as an alternative to the patent system, but potentially as a complement. I mean, we know Ben Rowan, for example, has written about how the patent system and many others here actually really can kind of distort the decisions of which kinds of innovations to work on early on. For example, if you think that a drug is, has a large danger of being found obvious, in the sense that people think, oh, maybe that could actually work for this disease, then the pharmaceutical company is less likely to actually take it through all the clinical trials, which really I think shows a sort of distortion in what we're rewarding. What we're really rewarding you for is not the initial idea, it's the work going through clinical trials. And so maybe we can fix that in the patent system, but if we can't, maybe then something along the lines of what Bhaven is talking about could be very useful. If we have a government role, then the question is ex ante versus ex post. And I've tended to be an advocate of ex post type rewards for a couple of reasons. So one, with the ex ante, I worry, there's a lot of familiar worries about kind of grants that people may be less likely to fund moonshots, for example. And you might argue, no, that's just an institutional detail. DARPA funds moonshots and so on. But I think that ex ante grants are more likely to be susceptible to political pressures. That if there's kind of political pressure to work on A or B, or some ideas are out of the mainstream not to work on those, I think those are less likely to be funded. And so the benefit of ex post is that maybe, even though social welfare is hard to measure, as we discussed before, maybe it's easier to measure past social welfare than it is to project future social welfare. And especially if we can kind of push the decision off in time, so to where we don't even know who the people will be, who the decision makers will be. Even if we think maybe they won't get the models right and they'll make mistakes, to the extent that that kind of cancels out in expectation, you think, well, maybe they'll do a little too high, maybe they'll do a little too low. We may get better allocations. And especially if you think there are some potential investments that might make a huge difference in the future, those are not likely to be fully funded ex ante, I think. But the things that we should still be worrying about, like antibiotic resistance, it's quite possible that ex post people will say, hey, yeah, developing a new antibiotic turned out to be really great once all the other ones turned out to have problems of resistance. I think we're more likely to get funding on that from ex post rewards than from ex ante rewards.
Daniel, you want to share your thoughts?
Yeah, I definitely agree with Bhaven that we should be spending more on pharmaceutical development within the federal government. Lisa and I think in our first article together said, it's kind of weird that the process of getting a drug through FDA review is something that we have allocated to the private sector, right? That dealing with a federal agency is something that the federal government can't do, only pharma can. And the amount that we spend on the NIH is really, really low. We spend $30 billion a year on the NIH. We spend something like $705 billion a year on the Defense Department. And I think I'm much more likely to be killed by cancer than by invading Russians. Right? So I think we should have more ex-ante government spending. That will probably require, or in order for it to be maximally effective, we'll probably just have to get comfortable with paying government employees more. So at the NIH, the salary tops off at about $418,000 a year, which is what Anthony Fauci makes. If you are really good at drug development and you want to make money, you'll leave the NIH and go to the private sector. There's no reason why that needs to be the case. We could pay people who work for the NIH more, or for a new agency within HHS that focuses on sort of end stage development. And I think it's also important to remember that the ex ante ex post distinction, well, to the Pfizer employee, the rewards are really ex ante, right? The Pfizer employee career advancement might depend upon whether a particular drug development effort works, but she or he is a W-2 employee who probably has some incentive compensation feature to her contract, but she doesn't own the rewards for the innovation. We could have incentive compensation within the government too, right? We just have to get comfortable with the idea that there will be people on the government's payroll who will be making more than $500,000 a year. The last point that I'll make is one reason why we spend so much on defense is because we've created this military industrial complex. We have companies like Lockheed Martin and Boeing who are essentially created by the federal government to then lobby more for defense spending. And maybe, you know, we need, and we kind of already have, a pharmaceutical industrial complex where we give some rents to pharmaceutical companies so that they then lobby for more government spending on pharmaceutical research. That's in no way an optimal structure, but you know, sloughing off some rewards to the private sector may be a necessary ingredient of getting the public sector to spend more.
Great. So I saw we're going to have a CLE interruption soon. I don't know if that can come now before we start discussing this, or.
Yeah, great. Thank you so much. Hi, everyone. I'm Kevin Chow, the executive editor of JIPEL. I will be announcing your CLE code, so get your papers and pens ready. The code for panel 1 will be LAB, L-A-B, LAB. So I'm just going to keep this up for another 10 to 20 seconds. Panel 1, the CLE code, LAB. If you do not have an attestation form, you should have either gotten it in an email from Michael Weinberg, or you can go to the page's Eventbrite, the Symposium's Eventbrite page, and there will be a download link where you can acquire the attestation form there. We will be sending a follow-up email via a Google, to the email that you used to register for the event. We'll have a Google form where you can upload the form afterwards. Please also make sure that your display name matches the name that will appear on the form. So once again, that's CLE code LAB for panel 1, lab. Pardon the interruption, and we can get back to it. Thank you so much.
Great. Thanks, Kevin. So we have a little less than 20 minutes left in this panel to continue discussing this. And one thing I'd like to get at on this institutional question is going back to a question Amy Kopczynski raised earlier in the chat about the funding for things like vaccine development versus state, local public health departments. And does this question of the right institutional mechanism for rewarding innovation, I mean, primarily we have been focused on new drugs and vaccines and kind of specific concrete products. I think we probably would all agree that there is like an even bigger problem with funding for things that are less tied to a tangible product, like public health measures. Are there ways to improve the institutional mechanisms for those kinds of innovations?
Yeah, I mean, I think it's a hard question both on the public and private sector side, right? I mean, so there's no lobbies for prevention. There's no, you know, so in terms of thinking about that kind of stuff, it's hard on the public sector research funding side to generate much momentum, which is probably why prevention and things like that have been relatively underfunded. Another thing to point out, I mean, if we just think back to market failures, though, and here I think we might be able to make a little more traction, it's just that there's market failure on the diffusion side as well. So going back to this idea that we have this kind of science and technology push strategy, we kind of assume that diffusion will just happen, right? And I think one thing that we've learned from this pandemic, and it's unique, obviously vaccines are unique for their own sets of reasons, is that part of the process is not automatic either, and some sorts of investments in government responses or government responsibility for those kinds of activities might also yield high social returns. Yeah.
One thing that I think is challenging is that it's very hard to know for the government to figure out what the returns are going to be from different investments and whether there will be returns at all. And one nice thing about an ex post system that's reliant on the private sector to kind of produce innovations and diffusion and do lots of different steps is that the private sector then has the incentive to think, well, how fast can we do things? So I guess in the comments, Amy also says, well, she doesn't think that we necessarily could have had the vaccines much faster. And there's certainly some empirical uncertainty there. I think we probably could have. I mean, there's certainly evidence that some factories were, new factories and new buildings were opened. And yet I wonder why weren't more open? If we were producing more vaccine per day, we'd be able to get through this a lot faster. But the deeper point, I think, is that it's going to be hard for government to make those projections. Private sector will make a lot of errors too. But when you tend to move the rewards ex post and make those rewards proportional to the contributions, at least partly proportional to the contributions, if you make it so that you say, well, look, if you get us out of this pandemic, a bunch of months earlier, we're going to give you tens of billions of dollars. That's how we can find out. And I think that's a more general lesson, even when we're not dealing with a pandemic, that, if we put everybody on the government payroll, I think the incentives, first of all, I think people are not just politically not going to like the idea of people making more than $500,000, more than the president of the United States on the government payroll. And you say we have to get comfortable. I just don't think people get comfortable. And, the broader point there is that those decisions are political rather than economic. And so I think if we push more toward ex post rewards, we can target social welfare while still giving private incentives for production.
I'll add 2 points. One, I think Amy is right in the chat that we would not have had emergency use authorization approval a day earlier if we had put more money into vaccines. I think there is a question whether we would have more vaccines on the market today if there were 20 BioNTechs and Modernas rather than 2. But the rate limiting factor was the clinical trial process, not that it took Moderna and BioNTech so long to develop their vaccine. But Moderna had an effective mRNA vaccine for COVID-19 probably before most of us knew what COVID-19 was. And then on the, I think Michael is right that you can give huge rewards. The government can politically give huge rewards ex post. And then that means that the private sector will make a lot of wasteful or unsuccessful investments along the way that won't pan out. And we currently are in a political environment in which we feel comfortable having the government give large ex post rewards to pharma and less comfortable with publicly funded efforts in the health space that don't pan out. But I don't think that is necessarily that's a political constant, right? In the defense context, we tolerate a lot of spending on threats that don't materialize, and we're okay with that. So if we could shift to a world in which we thought of public health threats the way we thought of national security threats, then I think we could do a lot more of this kind of in-house. And my understanding is we actually probably not more than $1 million, but we paid some weapons scientists a lot of money, keeping them either within the federal government or nominally working for contractors, but rewards essentially ex ante. So if we could do that for pharma too, then I think we could have kind of more on the ex ante side.
One quick response just on the issue of could we have done better. One thing that I thought was striking was that we didn't see the pharma companies pushing for challenge trials, and there are some bioethical debates, but there were plenty of papers written by bioethicists saying maybe this is the time that that it's actually ethical to do trials. And it's not like the government convened all the ethicists and they said, oh, we can't do it. I mean, there wasn't really a decision. It was just sort of a default thing, and I think that's because the pharma companies had little interest in getting everything done faster, and because it didn't matter from their perspective whether they use challenge trials, which can be a lot faster, or the long trials, because either way they're going to get paid eventually, and that's just 6 months to a year difference. And if anything, they might be better off having the pandemic go a little longer, as long as their competitors, don't beat them to the punch. But the problem is with something like those issues, if one company gets it, then everybody's going to do it, and so nobody pushes for it. Now, maybe that's the right decision on ethical grounds, maybe not. But I certainly don't think you see incentives for any kind of outside the box thinking that will really, move things forward. And I think that's more broadly a danger. The outside the box thinking, especially if you have to maybe try to get rules changed or try to advocate, maybe if we want the pharmaceutical industrial complex, we need to think about the incentives that complex actually has. And it's not always to advance public health.
I just want to push back a little bit against the idea that the public sector that it's difficult for them to take risks and tolerance for failure and whatnot. I mean, yeah, but we do spend, I think now, $40 billion on the NIH, which primarily funds basic biomedical research. I'd say, under the guise of, it's the National Institutes of Health, not the National Institutes of Biomedical Research, under the guise of producing health outcomes. And I'd say, 95% of it doesn't actually result in anything that actually links to any health outcomes. And the NIH has perennially been a fairly popular agency and about, bipartisan support that's unrivaled in I think, health policy. But you could have, and I think it's a useful discussion, you might argue that nonetheless, within that bureaucracy, you want to change incentives to take on more risk-taking behavior and whatnot. And I think there's serious proposals, from adopting parts of the HHMI model to Pioneer Awards, and there might be ways that you can tweak the kind of incentives facing not internal NIH scientists, which are a small part of the game, but external researchers funded by the NIH. To do so on the basic research side. I think the applied research side is probably a different set of issues, and we don't really know that much about that, partly because there haven't been that many experiments in terms of government funding of applied research in medicine.
I think it's kind of more broadly, this discussion is highlighting some of the error costs in relying on all of the different institutional mechanisms. And that one broader challenge in these discussions about innovation policy is that they often are focused on pointing out the flaws in a particular mechanism while assuming an idealized version of the other one. And the same reasons that we have underinvestment in preventatives by the private sector, it's kind of very similar flaws that lead to underinvestment in preventatives by the public sector. I don't know what the right way is to move beyond that. I mean, I like Daniel's point that we spend lots on the military and defense spending on preventing things that never happen. And if we could somehow shift the public debate to thinking about threats in the health system the same way, that would be useful, but I don't know how to.
Well, this might be a good moment to do that, right?
There's one other dimension to the defense versus medical, which is that the medical spending helps everybody in the world, which of course you might think, well, that's even better. But on the other hand, it also suggests that the optimal locus of organization is global rather than national. And to the extent that over time, U.S. GDP probably becomes smaller relative to world GDP, that's going to be more of an issue, and there might be more political pressures. People say NIH, well, most of that, our direct benefit from that spending may get to be a relatively low percentage, and I think there could be political pressures against that. And so, obviously, there have been discussions about international institutions that might fund medical research, and maybe that's a little bit beyond our scope, but certainly an important thing for people to be thinking about.
Well,
I think it's worth bringing in. Go ahead.
Daniel, please.
Well, I was just going to say, I think the defense analogy is a great one, in that we did decide that we would be the world's policeman, and we would defend Western Europe and not really make them pay for it. Now, it may be that kind of in retrospect, American hegemony benefited the rest of the world less than we thought it did at the time. But in that context, we allowed the rest of the world the rest of the free world to free ride off of our efforts. So why not do the same in pharma?
That
If I
doesn't
could
seem
just,
to be as politically popular now. I mean, that's just my sense, and I suspect that may be true in pharma too. I mean, I'm making a political prediction. You know, if you take global welfare into account, I'm certainly in favor of increasing spending to the NIH. I just don't know that it's as politically viable as it might be.
well, I think another just maybe a more prosaic difference between DoD and NIH is, I mean, DoD explicitly acts like a mission-oriented agency. I mean, it's got some specific goals, right? And it funds research to achieve those goals. The different parts of HHS kind of don't really talk to one another. I mean, this is kind of Bert Weisbrod's old healthcare quadrilemma article. In some sense, you know, Medicare is not kind of going back to NIH and saying these are the specific priorities, and so it just doesn't function in that sort of way. Putting aside any of the kind of Beltway bandits kind of lobbying, it doesn't see itself in that way. Those are two different arms, and that seems like some sort of integration might be useful.
We have about 5 minutes left. One question in the Q&A that we haven't got to is from Annette Godino asking about kind of who should be rewarded, the difference between the reward to the scientist at the firm who is doing the research versus the shareholders of that firm. We've been thinking about these institutional mechanisms at a bigger picture level. Do any of you have thoughts on that issue of the rewards for the actual scientists and what policymakers should be doing in that regard?
Well, I think a lot of times individual scientists, you know, can benefit from kind of awards rather than rewards. I mean, you need the shareholders to have some incentives to hire the scientists, but you know, maybe you can provide direct money to scientists as well. But I think it's probably, you know, the kind of prizes you put on your wall might be a better way to recognize individuals. And if you want to get kind of institutions funding large projects, I think you need to have financial rewards. Not entirely. I mean, there's certainly lots of institutions like open source software that work more on the basis of kind of recognition of individual contributions, but I'm skeptical of how well that can be scaled into the pharmaceutical space.
Yeah, it might be helpful to distinguish between sort of the Pfizers of the world and the BioNTechs of the world, or the Modernas of the world. There are some companies where, you know, the vast majority of equity is held by shareholders, and the scientists who are doing the work are not the ones who are getting the rewards. But there are a lot of companies that are involved in COVID-19 related R&D, particularly on the vaccine front, where it is particular scientists who are becoming multimillionaires or billionaires because of this. There's still sort of a superstar economy there where it's a few scientists, but it's the people with MDs and PhDs who are getting rich. And I think that kind of exacerbates the problem of how do we get the best kind of R&D minds to stay within NIH or within a new kind of applied pharma agency within HHS. There are the people like Anthony Fauci who are willing to live sort of a top 1%, but not top 0.001% lifestyle because they're public servants. But unless we increase rewards for government scientists, we're going to be relying a lot on the good graces of the future Anthony Fauci's for that.
Great, so we have 3 minutes left in the panel, so I thought we could conclude by just giving each of the three of you a minute to wrap up with any concluding thoughts, including if you have if you had to give the tweet size version of, for people who haven't been thinking about rewards for medical innovation, like what do you hope they take away from this panel? Michael, you want to go first?
Sure, I didn't write, I have a tweet prepared and I'm probably running over my 140 characters. But, you know, one thing I would say just as a closing is that it's important ultimately to find ways of funding kind of all the stages of research. And I think that's a theme a lot of us have hit on, including the development of the idea for drugs, but also the clinical trials, also the manufacturing. And that's where especially I think we've kind of fallen the most short in COVID. and even to some extent the marketing, although we all know that there can be excessive amounts of marketing. And so if the government is going to be focusing in Medicaid or other kind of programs on these things, it should probably be thinking about, well, where do we fall the most short, and trying to kind of add extra incentives on that.
Daniel?
I guess it would be something like more spending on innovation need not come at the expense of access, but will require political will. It's about 280 characters, so I'll stop there.
Thanks. Bhaven.
Yes, it's quite an exercise. Start from the outcomes we want and work backwards. I think the pandemic taught us that that's a useful way to approach biomedical innovation policy. Start from the outcomes and work backwards to the types of investments and institutions you need.
Great. Well, thank you so much to all of you for having this discussion. There's a lot more we could say, but we are out of time, and I will turn things back over to Zach.
Thank you, Lisa. Unfortunately, I have to be the villain throughout this event and tell people to stop talking when I could keep listening to all of you talk for the rest of the evening. I think your panel did an excellent job at really hitting at the core of that issue, which is governmental spending is an expression of priorities. It's an expression of our national values. And after this pandemic, is there going to be a rethinking of national priorities? I thought Daniel's point of, am I more likely to be killed by cancer or invading Russians? That's a pretty compelling question after this pandemic. But thank you all. I thought that was masterfully done. So right now, for those in attendance, we have a 10-minute break. We will come back at 1:40 with a panel moderated by Chris Morton. With that being said, go get some food or something. We'll be right back. Thank you.